blood.
Andrea, how much coffee have you had today?
Not enough, I think. I don't know.
Andrea, you're convinced that your smartphone is spying on you.
I definitely am convinced.
What happened?
Because we were talking this morning about the blood and all the things that the blood says, and instantly on my phone, it said they were having a sale on blood tests, which always makes me laugh because it's like they're having a sale on blood tests. And sometimes it says, for Mother's Day, give your mom blood work. I'm like, oh, happy Mother's Day or happy Father's Day. Here's some blood tests.
This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's great to see you two.
Hello.
Hi there.
All right, we thought, what better topic than blood?
Blood.
That was a terrible Transylvanian accent. But what your blood can tell you about your metabolism. I think this is really interesting. Yeah, a lot. Dr. Cooper, let's set a baseline because the first thing that you do when a patient comes to you is extensive blood analysis. Tell us why that's so important.
Yeah, the blood is really a window into your whole health and your metabolic system. So without that information, you're really just guessing. So I love that data because it's an objective way to look at someone and find out what's really going on. Because as we always say, you can't tell from the outside what's going on inside. So looking at blood work really helps identify who's at risk and who's not, and what types of strategies might be useful to help someone improve their health and their metabolism.
So we're going to be talking about things like blood sugar. We're going to be talking about various hormones in the blood, cholesterol, particles. So this is going to be really interesting, Dr. Cooper. I think we should start out by answering the question, what is A1C? Because it seems like almost every night I'm watching TV and there's some ad that talks about A1C, and I still have no idea how they calculate it and what exactly that is. What is A1C and why is it so important when it comes to understanding our metabolic health and also our risk of diabetes?
And what does A1C mean? What is A? What's 1? What's C?
Amen, sister.
Well, and it even starts out with an HB. So
oh, God. Who knows what that is?
A1C is the nickname for HbA1c, which is the abbreviation for hemoglobin A1c, which refers to the percentage of our hemoglobin that's saturated with glucose. And so it's actually measured in a percentage. Hemoglobin is actually part of our blood component. And when you think about it, we make new blood about every 3 months. And so our HbA1c level reflects the amount of hemoglobin saturated with glucose for the past 3 months. And so it's a longer term marker than just looking at glucose, which is blood sugar. So this is looking at a long-term blood sugar measurement. And so it can be very helpful to determine whether someone's been in the normal range over the long term, or if they've been in a pre-diabetes range or at full-blown diabetes range.
What I don't get, Dr. Cooper, is how in a blood test does it understand the time component? So we're looking at a 30-day, 90-day? How can you tell?
How does it know?
Yeah.
Well, again, because the blood is turned over every 90 days. Our blood really has a lifespan of about 90 days. sometimes 90 to 120 days before we're replacing it with new blood. And so by looking at this measurement, we're picking up that blood average over that past 90 days, that average glucose over the 90 days, just by looking at this percentage of the blood that's saturated with glucose. And so it is weighted more heavily to the current month. So that is one thing. It's not, even though it does span that 90-day profile, it's thought to be more accurately measuring the past 30 days, but influenced by the 60 days prior to that. But it sounds like an exact science, and it actually is not. One of the big problems with hemoglobin A1C or HbA1c or A1C, one of the big problems is there's a lot of error in that test, and it's known to have a lot of variance. So I think laboratory scientists are trying really hard to find a substitute test or improve that test quality, because there can be an error margin that would make the difference between whether you really have prediabetes or you actually have diabetes, or you really have normal glucose averages, or you have prediabetes. So that's why it's good to measure these things sequentially and along with other markers as well.
But for now, it's the only test we have.
It is. Well, and since it depends on the hemoglobin, things like changes in your hemoglobin levels could affect that result too. And so it might be that it's going up or down, not really because of your blood sugar, but because of changes in your hemoglobin concentration. So on the blood test, you'll also be able to find something that says hemoglobin. And so if you track that, is your hemoglobin very stable? Then you could probably feel like your HbA1c number over time is also pretty accurately reflecting things. But if your hemoglobin is always going up and down and up and down, and that happens due to things like anemia and other conditions, then your HbA1c marker may not be as accurately reflecting the truth about your glucose levels.
Which is why we have other blood tests that we do very frequently.
Exactly.
And we're going to get to those. But first, Dr. Cooper, what's a good A1C number that we can be proud of?
And show our teachers.
Technically, the normal range is 4.8 to 5.6. And prediabetes is 5.7 to 6.4. And diabetes is 6.5 and higher. And uncontrolled diabetes is above 7. So those are the standard ranges. But if you're always at 4.8, which is the bottom of the normal, that might not be so optimal, because we do need, a good amount of glucose to fuel our body. So it may be more beneficial to be just a little bit higher than that.
So at risk of oversimplifying diabetes, if we see an A1C number that is elevated, that indicates that our insulin is somehow not being produced or not working to take that energy out of the bloodstream into the muscles. So is that a fair statement to say?
That's the most common thing that would be happening, but there can be other causes. But if you do see that elevation of the HbA1c, and say that's the only thing you see, but you see normal fasting glucose and you see the HbA1c is in the prediabetes range or even the diabetes range, if everything else is normal, in order to make that diagnosis, you have to test twice consecutively and see that same marker being elevated twice, whether it's the fasting glucose or the HbA1c. So that's something to keep in mind. But the most common cause of prediabetes or diabetes would be that the insulin levels in your body are not adequate. Either they're insufficient or they're not working properly to deliver glucose to the tissues that your body uses. The most common cause of prediabetes or elevated HbA1c is a dysfunction of insulin, the hormone insulin, because insulin is responsible for helping the cells take up the glucose. It helps deliver that glucose to our body tissues. And so if our insulin is either insufficient or something's wrong with the way it's working, that glucose will build up, and then you'll see the elevation of the HbA1c or the glucose levels.
So you do this test usually at a fasting level What does that mean? Like, why do you do it at a fasting level?
Yeah. And so the standard normal ranges, especially for glucose, fasting glucose, involves a fast of anywhere from 10 to 12 hours. We sometimes will still test even 8 hours because that window is usually sufficient to get back to fasting ranges. So fasting overnight is the best thing to do for the fasting glucose level. The HbA1c, it's not as important because that, again, is a longer term marker and it's not influenced by fasting or non-fasting.
It's sort of like HbA1c. It knows everything. Can't sneak around.
Yeah, it's one of those, the funny thing is there are cases though where there are false negatives with the HbA1c, meaning that the HbA1c can look totally normal when somebody is really experiencing full-blown diabetes. That's very rare. And that would be in cases where, again, the hemoglobin is affected, people with various conditions like spleen dysfunction and things like that. So then we have other markers that we also check in those kinds of situations to confirm what's going on.
And Dr. Cooper, we should say, and I think we did this in a previous episode, we talked about these glucose meters that people are just obsessed with the idea that our blood sugar somehow has to always be low. But like everything in our body, there are cycles, right? Talk about this cycle of when we eat and how that relates to insulin levels and glucose levels in our bloodstream.
Yeah, it's just like with almost everything. There's a sweet spot there for glucose. The sweet spot's not at the bottom of the curve. In fact, we've talked about this in other episodes that had to do with memory, cognition, dementia risk. We don't really want our glucose to be at the bottom of the curve all the time because that means that our energy availability in our system is always at a low point. We need the glucose in order to function, especially our brain and our organs. We need that glucose. And so being in a normal range with your glucose is really optimal. Being too high or too low is not healthy. And so sometimes with the glucose monitors that people are using, I think there's a misunderstanding because we'll encounter patients a lot that say, I got this glucose meter and I'm noticing when I eat oatmeal, for example, my glucose just spikes up right away. So I stopped eating that. And now I'm just eating just eggs or something, eggs and bacon or something. When we ask further questions, what they're seeing with that glucose elevation after eating is completely normal. That's what is supposed to happen when you eat. That's why we measure glucose in the fasting state for a fasting level. And then we have different ranges of normal when we eat, and it's much higher. So a lot of what people think is a glucose spike is not at all a spike at all. It's just a natural response. And so if we're going around trying to squash that natural response all the time by altering our diet, we're going to end up starving our body of glucose. And so that's not really a good goal to have.
And that speaks to how important fueling your exercise is, right? Because when you're burning all that energy, it's got to come from somewhere, right? So you've got to have some blood sugar in your system, right?
Especially with exercise, because exercise is so reliant on just glucose being readily available, not just in your bloodstream, but the muscles having an adequate storage of glucose, your liver having an adequate storage. Unless you want to just be the slowest person in the pack and not recover well after the workout, you really need to have just optimized glucose stores for your energy levels.
Well, that's why we do those tests where I call it the eating test, where you test the glucose and the insulin at 30, 60, 90, and 2 hours to see how all the levels.
Right.
Like that's one of the tests.
That's a test we do for sure, because we're looking at the difference between fasting versus having eaten. And we didn't really talk about insulin much in the testing process, but just looking at the glucose alone could tell you the glucose is high or low, but it doesn't really shed much light on the mechanism without measuring the insulin. And so insulin's just a fantastic lab test that's really underutilized. And looking at the fasting insulin, especially with somebody who has elevated glucose, but a normal or a low fasting insulin, that has its own significance versus somebody who has high insulin and an elevated glucose. It's a completely different situation.
Wow, because your insulin, which is a hormone created in the pancreas, your insulin is produced in relation to how much you've eaten, when you've eaten. And it's this dance, right? It's this interplay of your body sensing that you just ate something and your body then producing insulin to help that energy get into the tissues. It's such a fluid and dynamic dance, isn't it?
It really is. And insulin is an anabolic hormone because it is so reassuring that we are nourished. When we have insulin on board, it sends a signal throughout our body that we're nourished.
What does anabolic mean?
So anabolic means it's a hormone that lets us build muscle and build healthy tissue instead of breaking it down to try to get energy out of it. That's why insulin is very helpful for retaining lean mass and all of that is very important. So that's the other reason why insulin also, for people in the general population, insulin has a bad name, and where it seems like people's goal is always to lower their insulin. But one of the worst situations you can be in is to overly suppress your insulin through things like low carb diets or underfueled exercise. Because insulin is an indicator that we're nourished. So if we're not nourished, you can end up suppressing it abnormally. And the way that happens is your brain actually decides to do that because your brain senses that there's a deficiency of energy availability. And so the brain, which is a fortunate organ in our body, it doesn't actually need the insulin in order to get access to this fuel, the glucose fuel, where the rest of the body does. So the brain, through the nervous system, can actually cause the pancreas to not emit as much insulin just because the brain wants to steal the glucose that's in the circulation away from the other tissues like your working muscles. So if you just are starving yourself all the time of carbohydrates or trying to get your glucose and your insulin levels down all the time and very focused on that by eliminating carbohydrates and other foods and not fueling your exercise appropriately, you could end up with abnormally low insulin levels. And that would show up on a fasting lab test. And at the same time, because of that, the glucose builds up in the bloodstream. And it can even go into the prediabetes range because of that. So that's the situation where it's not the thing that people think of a lot of times when they have prediabetes, that it could be that they just need to eat more regularly, fuel their exercise, and eat more carbs.
A crazy diagnosis from a doctor. Eat more carbs. Is this what I've read somewhere about selfish brain, which sounds so selfish.
Yes.
Is this what it is? Like your brain grabbing up everything?
Yes, this whole dynamic is nicknamed the selfish brain phenomena. It was termed that, but it's also called cerebral insulin suppression. It's also called cerebral brain pull, or brain pull, which means the brain pulling the glucose to itself away from the rest of the tissues. And so there becomes this great competition between the brain and body for the energy sources. And I find it fascinating that the scientists first discovered this in the 1920s. They realized this was going on. And we still don't pay enough attention to this type of physiology that occurs, because I see it pretty commonly in chronic dieters and especially athletic people who have underfueled for a long time, and they're drifting towards prediabetes, and they're just shocked because their lifestyle, as far as they're concerned, has been impeccable. But when you look at it, the underfueling itself is what leads to this type of action that the brain takes to protect its own energy supply. So it wouldn't be things like, typically our listeners probably have heard of meds like metformin and things like that that are used in prediabetes. But in this type of case, metformin won't really do much there, because metformin's role is to help reverse insulin resistance. And so it really isn't the mechanism behind this type of prediabetes. So behind this type of prediabetes, you're better off seeing a really good dietitian that could help you learn how to implement what we call ordered eating and fueling exercise and getting all your macronutrients back in with complex carbs, and then retest. Another telltale sign that you might be in that situation would be that the glucose elevations are during the fasting state. And the longer you fast, they keep going up. With diabetes that is caused by insulin resistance, which is a different thing, it's kind of the opposite. So there's lots of things you can learn from looking at the lab work if you actually do check these things and give it some thought. So I think that's the point of the lab work, is that no two people are the same, and that the surface numbers, they help enlighten you as to what direction there might be problems, but we need to look a little bit further at the mechanisms behind it and get some additional labs that give insight into those mechanisms.
Let's talk about some of the additional labs that you usually do for people. That I went to doctors religiously, regularly for years, and I never had some of those tests. Let's talk about some of those other tests.
Well, there are some common ones that are linked to metabolic dysfunction that are usually on routine panels, like things like your liver function. If you look at liver enzymes, they're often referred to as ALT and AST. Those markers can elevate in the setting of fatty liver disease, which now is being referred to as metabolic dysfunction associated fatty liver disease. So that if you see elevations of ALT and AST, or just the ALT levels, it could be an indicator. Now, if they're normal, it doesn't mean you don't have fatty liver disease, but if they're elevated, it's concerning. So that would be one thing that could point to metabolic dysfunction, and it's on a basic lab. Another one on a basic lab is triglyceride levels that are in the cholesterol panel. So if you look at the basic cholesterol panel, triglycerides and HDL cholesterol are very prone to imbalance with metabolic dysfunction. So if those are off balance, if you have elevation of your triglycerides and a suppression of your HDL, HDL is nicknamed the good cholesterol, but if that is suppressed and the triglycerides are elevated, that's a real indicator of metabolic dysfunction and probably metabolic syndrome.
And what is a triglyceride, Dr. Cooper, again, for us non-doctors?
For us dummies.
Triglycerides are fats circulating in the blood that is often measured as part of like the total cholesterol profile, cholesterol panel. It's like a standardized test. And so that's why I say that test and the liver enzyme test and the glucose, the fasting glucose, those are all very common tests that are run. And so looking at those gives some insight. But to enhance that, looking at the insulin levels, fasting insulin, and looking at the HbA1c, now you're getting a little bit bigger picture of what's going on. And then, as Andrea said, there's some others that are less commonly looked at, which have to do with the cardiovascular risk profile, which is also influenced by our metabolism, which has to do with the LDL cholesterol. And the LDL cholesterol is nicknamed the bad cholesterol. But looking at the breakdown of that LDL in terms of the number of particles, the size of those LDL particles, that gives you even more insight. And one other really interesting marker is called ApoB, apolipoprotein B. It's part of the cholesterol panel. And that one can really increase in the setting of metabolic dysfunction. And when it does, it increases that risk of plaque formation in the arteries significantly. And so these are all just looking at things from lots of different angles and trying to see, do we have clues that there's some type of metabolic dysfunction here? And if so, do we understand what that dysfunction is? And where are these imbalances and how do we target those?
Dr. Cooper, why is a fatty liver an issue? Why is that bad?
Well, fatty liver diseases can be really serious because the fat that's infiltrating that organ, it interrupts the normal function of the organ. And it can be extensively replaced. Normal tissue can be extensively replaced with fatty tissue there in the liver. And that can affect our liver's ability to function. Our liver's like a big detoxifying organ in our body, very important. But also, if it goes on and it's severe, it can lead to what's called fibrosis, which is a scarring that takes over and really can lead to full-blown liver failure. And so it's a huge concern. So I think catching metabolic dysfunction early and treating it before there could be progression towards these kinds of dysfunctions is really the key, because once you're in that where you've got liver fibrosis and extensive fatty liver disease, you really need to be seeing a liver specialist and trying to see what other options are available. You know, it's worst case, the liver failure can lead to need for liver transplant. I mean, that's extreme. But mild fatty liver disease is very common for a lot of people who are dealing with metabolic syndrome.
I had it and now it's gone.
Yeah, it can reverse with just our normal metabolic approach. But when it's very severe, usually that's not enough.
And you really can't tell just by looking at someone if they have fatty liver, right?
I had no idea.
Yeah.
No, you can't tell. I mean, the old-fashioned way was waist circumference, geez, most of your body fat, are you the apple or the pear, you know, those, but they don't really stand up to scrutiny. Ultrasound is a very good test for fatty liver disease. And there's also something called a fibroscan, which will look for that scarring and that fibrosis. So those are very good tests, and they're done with ultrasound and specialized ultrasound.
Dr. Cooper, when I first came to you, you told me that my testosterone levels were low. And this was all in relation to my metabolic syndrome. And so I was injecting testosterone into my thigh every 10 days. And it made me feel like I had a lot more energy. It made me feel more calm, which is interesting. And I didn't realize that men and women both have estrogen and testosterone in their bodies, and there needs to be a balance. And we're talking about what your blood can tell you. I guess this is one of the blood panels that you do just to see what is going on. Why is testosterone, why is estrogen, why are those hormones so important to your metabolic health?
You know, it goes both ways. Our metabolic health influences those hormone levels, and then those hormone levels feed back and influence our metabolic health. So they're very important tests for both males and females, looking at estrogen and testosterone in both groups, because both males and females do have both of those hormones, but they're just in different proportions, and they have different roles in men and women. And so men with metabolic dysfunction, often what you'll see is an abnormally elevated estrogen level relative to a weak testosterone level. And that's an interesting imbalance there. But what ends up happening and what causes that is if men accumulate extra body fat, especially the belly fat, there is an enzyme called aromatase, and that enzyme converts male testosterone to estrogen in the belly fat. So in that extra belly fat, they're getting that conversion of their testosterone to estrogen. And when that happens, the estrogen levels can start to rise too much, and they actually feed back into the brain, and they influence the brain signals that try to inform the testicles whether or not they should be making more testosterone or not. So what happens is the estrogen interrupts the normal testosterone production that way, and it inhibits the testosterone production. So right away, the testosterone gets kind of hijacked into estrogen, which doesn't have the same role, almost has an opposite role in men as testosterone. Then that estrogen disrupts further testosterone production. So that's a really kind of negative type of pattern for men, because they find themselves more tired because of the drop in the testosterone, harder to hold on to their muscle mass because of the drop in testosterone, and often mood issues where testosterone has this kind of improper image of creating rage in men, which I'm sure if you abuse it, maybe it does. But testosterone actually, on the contrary, has been found to be very calming to men and very reassuring, very kind of creates like this kind of optimism and a reduced sense of fear and worry and concern. And so it's very helpful for men's psyche, testosterone. So that reduction in testosterone can lead to all kinds of just, feeling not your best. And then the elevation of the estrogen for men creates female distribution body fat happening.
During that period, Dr. Cooper, I actually had some swelling in my nipple area, my breast area of my chest.
Yeah.
And was that a function of elevated estrogen? Is that what happened?
Yes, that's what happens. And so that's what happens. And it happens to young men. It happens to even adolescent boys when they have metabolic dysfunction. So these are things that just really, you can see the physical signs of it and you can feel the symptoms of it, but you can also see it in the blood tests. It's very obvious in the blood testing. And then when it comes to women, the estrogen cycle gets often disrupted with metabolic dysfunction in many ways. One would be if there's a lot of what we call diet damage, a lot of past history of dieting that has caused the body fat hormone leptin to be very low. Then you start to see problems where the brain is refusing to signal the ovaries to produce estrogen because the brain is trying to turn off fertility because it's sensing that there's not enough body fat, whether that's actually real or just a perception due to kind of a suppression of that hormone from past diets. So that could interfere with ovulation to begin with. So then in that case, you'll see suppressed signals from the brain and you'll see low estrogen. And so that's luteinizing hormone that we look at in the blood work and estradiol. But the other thing that can happen is there can be things, you've probably heard of PCOS, polycystic ovarian syndrome. In women who have that, often there's elevation of their androgen levels, which are testosterone. And there's another one called DHEA sulfate. And these are both blood markers. So these are all on our basic panel. Actually, we look at this whole array of things. But so those may be elevated. And in addition to that, the signals from the brain that are trying to tell the ovaries to produce the estrogen could be very high. The luteinizing hormone could be very high. And yet the ovaries are not responding to it. So they're under responsive to those luteinizing hormone signals. So in that case, you'd see the high androgens and the weaker estrogen levels. That's another sign of metabolic dysfunction. So we see all these different patterns in both men and women, but the reproductive hormones are very important because if they're not in the proper ranges, we don't feel as good, obviously. Like for women, when their estrogen is lower, their metabolism doesn't sense the body weight as well. And so that could cause a slowing of metabolism as well. And again, for men with that low testosterone, they can't hold on to their muscle mass very easily. And if they have elevated estrogen along with that, they'll just start gaining more body fat.
I keep seeing things about cortisol and how it's, your cortisol levels will make you happy or make you sad or make you magic or I don't know, make you a magician. I don't know, all these different things. What is cortisol? What does it do? What are my good levels, bad levels? What's happening there?
Cortisol is a hormone that the adrenal glands produce, and it's nicknamed a stress hormone. So it does help us adapt to stress, actually. So it's not a bad thing. It enables us to mobilize fuel and the energy resources when we're confronted with stress. And so we always look at what's the person's actual stress level and what's their cortisol. Is it appropriate for their stress level or is it seem too low or too high? So there is a kind of optimal range. Again, just like everything in medicine, there's like this sweet spot where too low is not good, too high is not good. And so if, say, you're extremely stressed and you're dealing with an awful lot of things, but your cortisol is at the bottom of the range, that means that your stress adaptation system is pretty much just exhausted and can't respond. You're not able to respond to that stress appropriately. And that could be for various reasons of chronic stress effect on you. That's not optimal to say, oh, great, my cortisol's low when you have massive amounts of stress. But if you have cortisol levels that are way over the top, that's not good either, because that is almost like you're taking a steroid, not an anabolic steroid, but a steroid just like prednisone or cortisone or like a medical treatment that would be a steroid. And steroids, as we know, are not great for our bone density. They can promote prediabetes and diabetes. And so they have a lot of potentially harmful effects. And so does our own natural cortisol if it's extremely high all the time. But it also serves as an anti-inflammatory hormone. So if we're injured, it should go up to help with that inflammation. So it's got this range of optimal, which is within the normal range. But so if you look at that normal range on the lab report, you don't want to be above that. And you also don't want to be at the lower quarter of that range, because especially if you are experiencing stress, then that's not appropriate. That means that you have an under-functioning stress adaptation system. And to get it back online, you're going to have to do something to rebalance that stress load.
What kind of things can you do to rebalance?
You always ask me that, like I'm the expert on stress reduction.
Well, because you know me, I'm always like, is there a drug that you can take for that? Can I just do... I always want the easy way.
One of our listeners actually sent me a message recently or commented on our Spotify thread that meditation is actually extremely helpful. So,
all right, there you go. That's sort of a drug, I guess.
But yeah, I mean, I think it's reevaluating your life, really. If you've gotten to that point, it's more than just...
that takes so long.
Andrea just wants a pill. That's awesome.
I do. What can I say?
Well, it's really been interesting, Dr. Cooper, all the things that we can learn from our blood about our metabolism. As we wrap things up, let's say a person listening is not currently seeing a metabolic expert. And when they go in for normal labs, their normal blood panels, what should they talk about with their doc when it comes to keeping an eye on this stuff?
Well, I mean, I think getting at least find out what your doctor is recommending. And then if you don't hear about insulin levels and A1C and these higher tech cardiovascular risk panels, maybe ask, how about adding insulin levels? And do I need to do the test just fasting or also after I've eaten to check anything? And just start asking some questions. And then there's a whole nother area that can be an issue, which is the interpretation of the results. Because as we said, there's these sweet spots. And so just being in a normal range isn't always like, it's great. You have to look at what's appropriate. So if your glucose is elevated, technically your insulin should be elevated to try to help pull that glucose back into the range. So if they're both in the normal range, but not in sync with each other, that's also a concern. I would still, even if you get the normal, if your doctor is saying, here's your results back and everything looks normal, have a full discussion about what the meaning of all of it is.
I think that for my doctors, they've never ordered the full panels of tests that you order. But when I show them the test, because I always forward everything to them, they love looking at all the tests and they're like, oh, this is really interesting. This is why this is, and we always have a great discussion about it. And I think it adds to their information about my overall health. And it's been really fantastic to have.
That's wonderful.
All right. We've learned a lot about what our blood can tell us about our metabolism. Thanks so much, Andrea, Dr. Cooper, for another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.